Hello, I'm Dr. E.W. Emanuel, the President of the Medical Society of the District of Columbia. Welcome to Washington Healthcare on Wednesday, or WOW, MSDC's weekly program devoted to informing and connecting the Washington, D.C. physician community. This week is the National Drug and Alcohol Facts Week, and we are turning our attention to drug and alcohol use in the medical community. Physicians have access to medication and other substances, and we work in a high-pressure environment that puts us at risk of burnout, or worse yet, substance use disorder and other impairments. So, it's a difficult topic, and to help shed light on it, we've invited our very own Dr. Charles Samenow, MSDC member and Associate Professor of Psychiatry and Behavioral Sciences at the George Washington University School of Medicine and Health Sciences. He also chairs our MSDC Physician Health Committee. I'll let him introduce himself and tell us all about the Physician Health Program. Dr. Samenow.
Great, well, thank you so much. It's wonderful to be on this chat and to reach out to our physicians across the DC area, but more importantly, expose folks to some of the truths around alcohol and drugs, and particularly alcohol and drug use within the physician community. The DC Physician Health Program, for which I chair, is a committee of physicians. It's a volunteer committee that is a helping peer committee at its heart. These PHPs were founded around the country as a way to help physicians who were having trouble, both with mental health and addiction problems. We now currently serve as a resource to intervene, to refer for evaluation and treatment, and then to monitor individuals as they return to practice and advocate with their employment, places of employment and the licensing board that they can practice medicine safely. This is a way to destigmatize the disease of alcohol and drug use among physicians, as well as mental health issues.
Thank you. So how long have you been doing this, Dr. Samenow?
I've been involved in physician health ever since I was in residency. At Vanderbilt, where I trained, they have a variety of different programs devoted to physician health. And so that's where I got the mentorship and interest in this area. They have a program down there for physicians who get in trouble for misprescribing controlled substances, for physicians who violate sexual boundaries, and for physicians who engage in disruptive behavior. And so I helped do curriculum development and program evaluation down there for those programs. And through that, I was introduced to physician health programs and the variety of challenges that physicians have in the workplace. So that was about 20 years ago. When I came to DC, I became a member of the DC Physician Health Program probably about 5 or 6 years ago, and I'd say I've been chair for about 3 years of the current program.
Thank you. Because it is National Drug and Alcohol Facts Awareness Week, can you tell us what facts surprise most people about drugs and alcohol in the medical community?
Yeah, I think what's most surprising is that physicians have a very similar rate of alcohol and drug problems for the general population. I think folks feel that maybe there's something protective about being a physician, or that because physicians are healers, that they would somehow be immune from this problem. But when we look at the data, what we see are the rates are actually very similar. What differs among physicians is the types of substances. Very few physicians are addicted to, crack cocaine or IV heroin. Physicians tend to become addicted to things they have access to: fentanyl, benzodiazepines, Percocets, pain medicines. And then, of course, alcohol remains a substance that's very prevalent among physicians who have problems.
Well, because of the COVID environment, we know burnout is increasing. And I would say COVID is a leading factor, and that we may find this information out in a delayed manner. But have you seen preliminary data that shows that our physicians have increased rate of use and abuse since the COVID pandemic?
I haven't seen data because I think, as you've said, we're in it right now. And usually alcohol and drug use is something that then follows it. It's the aftermath. So I've not seen any convincing data right now to show that rates of alcohol or drug use is up, but certainly markers that are precursors such as burnout, depression, physician suicide, all of those precursors, we're seeing spikes in the research literature and the lay literature that certainly has us concerned.
Yeah. Well, it is a stressful environment. How do we safeguard ourselves from these pressures that we have?
Yeah, I think, unfortunately, medicine just sort of the meta problem that we have in medicine of being great at curing disease, but not being as wonderful about preventing it. I think that is true of our own profession as well. We have developed wonderful resources now with these physician health programs to intervene and to identify physicians who are in trouble. But what we have yet to do is really find robust, wonderful ways in our medical schools, our residencies, and among our practicing physicians to put into place skills and tools to cope under pressure. Now, with that being said, most physicians do very well. Most physicians are healthy, strong, safe, practicing professionals. And the challenge, much like in the military, it's knowing who is going to, in a wartime situation, have a nasty perfect storm of the predisposing factors that they brought in with them with the current factors then that bring it out. And so that is a real challenge we face in terms of who right now really is at risk and who needs services. So the way to keep healthy, I think, is for us as peers to be looking out for each other and to really, as a community of physicians, really, look at our peers and recognize when we see those nonverbal cues to ask people, how you doing? How are you coping? How's your family? How is it having kids at home who aren't in school? I think the first step is to just name and raise awareness that we're all going through this together.
It's interesting because we are, from our training, we are taught to believe that we are leaders. Mm-hmm. And with that leader quality, sometimes it's difficult to ask for help or to expose yourself as being vulnerable.
Exactly.
How then in our culture do we elevate that? How do we say it's okay to be vulnerable or to ask for help?
Sure. Well, that's a major cultural change. And I think while it's not too late to teach old dogs new tricks, on the flip side, my most hope is those of us in positions of supervision and teaching to model that for our junior and our younger physicians, because certainly in our training, most of us who are in practice, vulnerability and asking for help were signs of weakness. That's yes. What equated to, or whiny, or non-honors, or maybe you can't hack it in the field. And so what we've got to do is change that culture to be able to show how vulnerability and asking for help are actually strengths, and how those are things that are not only strengths, they're essential to the practice of safe medicine. So one is role modeling, and that's why I say it's so important for us in the community to really be practicing that with our peers and with each other and those we trust in our office practices, so that others around us see and it becomes a new norm.
We have been taught, again, as physicians, that when there's an error, to acknowledge that the error is there. And it took some time for us to remove from a accusatory or blame environment to an accepting that this is a learning environment and that we make mistakes. Is there some effort being placed in acknowledging that burnout and use of substance may be approached in a similar way, that it's a learning environment and not an accusatory? Have we seen some changes there?
Well, I think that's the basis of the physician health programs, and certainly focusing on alcoholism and drug use as a disease, and recognizing that for the most part, these are exceptional physicians who are inflicted with the disease. And so our approach is to, in a non-stigmatizing manner, get these folks the help they need, but get them very quickly back into practice. On the training level, it still remains a very, very challenging area. Years ago, I heard Nora Volkoff from the National Institute of Drug Abuse say the number one challenge in promoting the disease model of addiction was convincing physicians of it. That until we convinced physicians that alcoholism and disease wasn't just a bad choice, alcohol and drug use wasn't just a bad choice, but it's actually a disease, that people have different genetic vulnerabilities that interface with the environment. And of course, there is a choice component to it. But just as with skin cancer, melanoma is a real disease, whether you choose to suntan or not, it doesn't take away from the fact it's a disease. That until we convince physicians of this, we're never going to make strides in the general population. And I think, if you look now years later, we just did a survey of our residents at George Washington University, which matched national data that I have from 20 years ago, that residents continue to be fearful of seeking help due to repercussions on their career. They have a difficult time finding accessible, non-stigmatizing help that fits into their busy schedule. And, confidentiality remains key. So, 20 years later, the data, and George Washington is no different than any residency institution across the country, we're still struggling with these same barriers. So we've acknowledged it, but in terms of progress, I think we still have a long ways to go.
Yeah, unfortunately, due to the stresses, you don't need to be in medicine long to be at risk. And you mentioned that that those in training are learning or being taught differently. But we're seeing this affliction occur in as early as medical students.
Yep.
What is the difference in the training for substance use disorder for these early career physicians compared to myself, where I trained at GW over 20 years ago, and it wasn't part of my training. Again, we were taught to be stoic, and any affliction like that was viewed as being weak and treated in more of a criminal factor rather than in a more gentle, caring health environment,
right,
or approach.
Well, I think there's a lot of interest right now, and there's a very interesting sort of overlap between wellness / impairment, medical student mistreatment / the learning environment, and things such as structural racism and cultural competence or incompetence, unfortunately. And what we're seeing is, as institutions become more aware of the toxicity that certain socio-political, socio-cultural systems are putting into place, we're starting to realize the impact it has. I mean, we know, for example, that underrepresented minorities have a much elevated rate of suicide in the physician population. And so the problem is, it's not a minority problem, it's a systems problem of what does it mean to be an underrepresented minority in a system that has these continued challenges around racism and cultural incompetency. Same thing for women physicians. We see a much larger than the general population. The antic is men are completers, women are attempters. But we see in physicians that women are completers. And again, it talks about gender bias and discrimination. So your question was, what are we doing about it? As these topics are being introduced into the curriculum, I'm seeing a lot more discussion now around mental health, drug abuse, suicide, racism, unconscious bias, homophobia, transphobia, gender bias. And so we're starting to see a sociological or social determinants of health approach that I don't think you or I got. We got pathophysiology, biochemistry, the pharmacology, the mechanics of medicine. But we're now starting to realize that the public health, anthropology, sociology, psychology is an important aspect of medical training. Again, a long way to go, but we're starting to see those areas start to infuse in our curriculum.
So it sounds like the great circle of life, that, the public health, in the public health realm, it's more than just not having access to healthcare alone that puts someone at risk for bad medical outcomes. I'm hearing that it's the same with our psychological well-being. Can you say a little bit more about that?
Yeah, I like to think about patient barriers, provider barriers, and systems barriers. So I like to sort of divide it up in those three domains. And so if we're talking about medical providers being the patient in this case, it's very hard. We don't think of ourselves as patients, but if you think about the impaired physician as a patient, there are barriers around stigma, barriers around access still. Even for residents, it can be very hard in this city to find affordable mental health care. The same for students. Luckily, most of us who are attendings, we have the ability to go out of network, but there's financial barriers. And so that crosses into systems. There is still provider barriers. There are providers out there who are not trained and not comfortable working with physicians. Physicians are a tough population to work with. We have our defenses up. We are good at intellectualizing, rationalizing, minimizing. And so if you don't have a skill set in working with physicians, you can easily be duped. So there are a lot of barriers out there. So we've got to get more people trained in this area, particularly around physician health. We need to get systems in place that ensure confidentiality, that ensure that seeking help doesn't give a ding on your licensing application and prevent you from, getting licensure or practicing medicine. And we've got to get the message out that seeking help actually will help your practice of medicine, not hurt your practice of medicine. We've got to convince people on the ground, trainees, to change the way we view accessing psychological services. So we have work to do on all three levels.
Well, I'd like to stick with that public health, and which I view as a big part of prevention. As a gynecologist, we know that most of us view, not all, that when a patient presents with cervical cancer, born in the United States, who have had insurance, questionable healthcare access, but insurance, and they come in with a diagnosis of cervical cancer, we failed them because we know that we can prevent cervical cancer, that there are pre-lesions that presents itself if we screen appropriately. I'm feeling that this area of substance use disorder, the impaired physician, burnout, may have different stages before they reach a point in which we need to intervene and they at risk of losing their livelihood. Is there a way in which we can place prevention at its forefront? Because once we label them as burnout, I think there's maybe a stage before that. Do you see any future? Is there any evidence showing that a screening program or identifying it, self-identification, as well as the health community, we as physician, our community, identifying our physician may help in that way?
Yeah, absolutely. First of all, kudos to you for using the correct terminology, substance use disorder. I just want to make sure on this webinar that we use the correct terminology, because substance use disorder is a dimensional diagnosis. There's mild, moderate, severe, and your question is about dimensions. Can we catch people in the mild phase as opposed to the severe impaired phase? And we're talking not just about substance use, but even things around depression or any kind of behavioral, psychological or behavioral disorder. And absolutely, the unfortunate data is that medical students show early on, even in about the second semester of their first year, increased risks of burnout, emotional exhaustion, depersonalization, et cetera. But the good news is we also see that those medical students will rebound. And so what we know about burnout is there is sort of a cyclical pattern to it, that certain as you go across the phases of medicine, there's certain areas, that first semester after the honeymoon's over and then it turns into winter and, you're in the depths of it, that's a risk period. The third year after you have your first or second rotation and you get into the depths of it, obviously residency. So there's parts, there's areas that we know, if we look at the research literature, that we know we're going to see cycles of burnout start to spike. The challenge is how to pull out those people that are, outside the cycle, because again, most physicians will rebound. Most physicians, they'll have ups and downs, but overall they'll become safe, healthy practitioners. It's those that are at risk. Who is it that will not rebound? Who is it that stays burned out? Who is it that progresses from burnout into more clinical depression? That's where I think we have the biggest challenge. And I don't know of good studies that have shown, great markers in that domain. Unfortunately, by the time a physician gets to the physician health program, it's too late. Very few people come to the physician health program voluntarily. They say, hey, they usually come here because the licensing board says you got to go there, or their employer says you need to go there or you're going to get fired. So we really don't have great programs that identify people early on. We kind of have this don't ask, don't tell mentality in medicine, which is, well, if you have a problem, you need to deal with it on your own, or the burden is on you to seek help or to come to us. But we're not going to probe or invade your personal life. So it's tricky. It's tricky.
Well, yeah, it is. Given the statistics, we know that, you know that we are currently working with people, or we have worked with individuals from the past who have suffered from substance use disorder. What are the signs of abuse, and what are the best way in which we can help those who are struggling with substance use disorder?
Sure. And remember, a substance use disorder in and of itself does not equate to impairment. There are, that concept of the functional alcoholic. The problem is in medicine, because we're dealing with mind-altering drugs and we are a safety profession, we err on the side of caution. And so PHPs have a little bit of a bad reputation, and that's another thing that I want to dispel right now, is we really are on the side of the physician. We want physicians to get help. We want to get physicians back to practice, but we are extra cautious because we recognize that we are serving the public in their most intimate and most important domain of their life, their personal health. And so for that reason, we feel we have a duty to ensure that, physicians are practicing medicine with the clearest mindset possible. So, there are general signs or worrying signs that someone are using alcohol and drugs. From the obvious, smelling it, seeing it, disheveled appearance. But the problem is physicians are very good at hiding this. Physicians will lose their children, their wife, their house, their car before they'll lose their medical license. Work is generally the last place that physicians will show their cards. And so generally, it's much harder to detect this in individuals. It usually shows up with erratic behavior, showing up to work late, working at odd hours, things that start to not make sense, excuses that just don't add up. These are the kinds of things, in the impaired physician curriculum, you often learn about the physician trembling, on the operating table. And that has occurred. I mean, we have had instances where a physician has had to be hauled out of surgery, but that is very, very rare. Generally, it's much more this erratic behavior and trouble when the family life trouble starts to encroach on the work life. That's when we start to notice that there are problems. But again, it's late stage.
Yeah, I would agree. And I would also say, you're absolutely right. We've seen it. Physicians will allow everything else to be lost before they will lose their medical license or ability to practice. With that, and I would say to you, I'm not sure if I would view the PHP as a safety net program. I would definitely view this as they are friends. They are for our physicians. But what can we do? What can you suggest that we do as a community or MSDC to help those who are impaired? Because we're not going to go to the EAP for assistance. What do we do then?
Well, I mean, the PHP is a place to come because what we will do is do a confidential evaluation and assessment.
Oh.
And so we will, we do not do the assessment ourselves. What we do is we send folks off to experts. There are a variety of programs in this country that are experts at assessing physicians. That's all they do is assess physicians, or attorneys or airline pilots or people in safety sensitive positions. Or high functioning professionals. And what they will do is do a multi-day comprehensive assessment and then give their recommendations back. And then what the PHP does is start putting that stuff into play, pairing people up to the appropriate outpatient resources, whether it be medication management, whether it be group or individual therapy. And what we simply do is tell the licensing board or the work environment, this person is safe to practice or they're not safe to practice. We do not share the personal details. We don't share why they're working with us. Oftentimes, as I said, the workplace knows because the workplace said either you go or you're fired. But for someone who confidentially comes to us and says, "Hey, I have a problem," sometimes we won't even let the work know because there's no need to. The person comes and simply, as long as the person follows the recommendations and stays in treatment, we don't need to do anything. But should they then get under the radar at work, we can say, "Hey, hold on, don't go a disciplinary route. They're working with us. Let us figure this out. We're going to get back to you with a plan." So we serve as a buffer between licensing boards and work and a physician's personal health information. There's no reason they have to disclose everything to those entities. We get it, and then we disclose that A, the person's working with us, and B, that they're safe to practice.
Do you monitor their progress?
Absolutely.
Their journey?
Yep. So if it's an alcohol and drug problem, we do urine drug screens, we do hair tests, we do PEth tests. If it's a behavioral health problem, we do quarterly reports. Sometimes we'll put an anonymous workplace monitor so that person will be able to give us reports that the person is at work and functioning okay. So we have a variety of different ways that we can monitor a person's progress and ensure that they're doing okay.
Does MSDC Wellbeing Program, Physician Wellbeing Program, have any association or alignment with this?
We are connected but separate. The well-being program is more of the preventive arm with coaching resources. So it's for individuals who are not in the impaired region, but are reaching out because they need help or want to become better at a certain area, or because they're struggling with burnout and need some skills and resources. Now, if through that process they identify that they need more, they can certainly be referred to us. But most of the folks in the well-being program are tapping into resources to, sort of help them stay afloat in a difficult environment, but they're not reaching the level of concern around impairment or safety.
The physician health program have been in place long years before the well-being program.
Correct.
Do you at any point refer patients to the well-being program when they come to you as helping you identify, they're still in the phase where we can prevent. They're not using, but they feel as though they're on their way. Do you refer back?
We don't see those folks. We see people who are about to be fired and lose their license. So we never get folks that early. I wish we got folks that early, but the folks we get, they're well beyond that, unfortunately. When they're coming to us, it's like emergency appendectomy time. Like they're about to lose their job or lose their license. And that's the unfortunate part. That's how they get to us. There are many, many physicians in the DC community, even in my institution, who don't know that we exist. They don't know we're out there. We don't know we're a resource. And so that's one of the things we've got to do a better job of, is letting folks know that, we're not just there for the emergency appendectomy. We're there to help anyone and get them to the right place. I wish we could utilize the well-being program more, but those aren't the cases we see.
Oh, I think because this is National Drug and Alcohol Facts Week, and because we do have a program that can assist those patients, I think this webinar is timely.
Absolutely.
Okay. Is there anything else that you would suggest or can help to surface the recognition, or that this program exists, even in your institution, in the DC community? What recommendations do you have for us to market this program more?
Well, I think it's, our referrals mainly come through word of mouth. And so that is helpful. But I also encourage anyone on any leadership committee in the DC area to constantly remind leadership that we exist, because when someone is under the microscope for concerning behavior, there are two routes to go: the disciplinary route, or the therapeutic route. And you talked about how when we were in medical school, it sort of was always the disciplinary route. That was it. But there are other options. There are medical leaves of absence. There are ways to preserve physicians. There are a small subset of physicians that do not belong practicing medicine. These are like, Swango, the infamous serial killer physician. But outside of that group, then it is a judgment call. How much do we as a profession want to invest in individuals who have given their lives, given their time, their money, their family, their psychology to become an outstanding healthcare provider and are afflicted with this disease? Sometimes a disease that is, fueled by the very profession that, that they're in. And so, I often say to folks, the easy route, it's not easy. There's always, say, get rid of them. Goodbye. We don't need, we have enough patients of our own. We don't need to start treating our doctors like patients. But the other route is the humane route, and the one that understands that we're a community there for each other, that when someone has a problem, why not afford them the same benefit we would afford our patients: kindness, compassion, and resources. And I think that's what we need to appeal to leadership. One very important, you asked, let me come full circle, like your circle of life. You asked me for a surprising fact. One of the most surprising facts is literature came out of a very large study in Tennessee. Physicians who had been in recovery, sustained recovery, and who had gone through PHP programs had a lower malpractice rate than the general physician population. Malpractice insurers love physicians in recovery because those physicians have done self-examination, self-reflection, learned to be vulnerable, learned to be open. And as we know, a lot of malpractice outcomes is based on the doctor-patient relationship. And there is something about doctors who've gone through recovery that leads to far lower malpractice lawsuits, claims, and rates. And so treatment works not only on the individual, but on the system.
I think that's a great fact that you gave us. So before we close, is there anything else you want to say about substance use disorder as well as our PHP program?
Sure. Well, one, the PHP exists. Every single state has one, except for, I think, California right now and maybe one other state, but pretty much every state has a PHP. And then number two, with substance use disorders, disease model, disease model, disease model. No matter what your training, bias, approach, even life experience is, we got to recognize that it is a complex biopsychosocial, cultural, spiritual phenomenon, and that if we don't, as physicians, approach it as a scientific and disease model, then we become basically perpetuating the same stigma and poor outcomes that keep this disease. We fuel the fire rather than treat the fire.
Thank you. I hope our physician community have enjoyed this important discussion. And I want to thank you, Dr. Samenow, the MSDC physician, the chair of our MSDC Physician Health Committee. I'd like to also say, for more information about the Physician Health Program and addiction resources, please visit us at msdc.org and look under for physicians. For more information on our WOW series, please visit msdc.org/WOW. Again, thank you, Dr. Samenow, for this important discussion.
Thank you.